This is a presentation about tracheostomies, the indications and complications. So the objectives that I'd like to get out from this talk are that we should understand why tracheostomies are put in. We should revise the difference between a tracheostomy and a laryngectomy. We should know what to do when things go wrong. And I've put in some interactive elements, so I'm afraid you are going to have to watch along and not simply have Netflix open in another window. What I'm not going to cover is there's no teaching on how to fashion a tracheostomy, either with a biro or otherwise. And thanks to Paul James, who gave me some of his slides, which are quite beautiful. So we'll start off with the history and indications. When is the first reference to a tracheostomy? I'll give you 30 seconds. So here we've got some Egyptian tablets showing possibly the first depiction of a tracheostomy, or if you look at it the other way, a human sacrifice, but hopefully a tracheostomy. Also reference to tracheostomy in ancient Hindu and Chinese medical texts. In more modern times, the first reliable description of a successful tracheostomy, and you shudder to think what happened before then, is by Antonio Musa Brassavola, and that's definitely how you pronounce that, in 1546. He performed the procedure for the relief of airway obstruction from enlarged tonsils. Which US president died through reluctance to perform a tracheostomy? Again, I'll give you 30 seconds. So this slide shows some tracheostomies from the 19th century, some made of silver, by which time it had become relatively commonplace to perform tracheostomy. George Washington was probably the most famous person to die through lack of a tracheostomy. He developed acute epiglottitis, and his attending physicians didn't have any experience in performing the procedure. Bottom right is obviously not a 19th century tracheostomy. That's our current kit, showing the development through to plastic and the development of a percutaneous procedure over an open surgical one. If you look at the indications for tracheostomy, they can probably be thought of in the following way. Emergency tracheostomies hold a high mortality rate compared with endotracheal intubation, which is probably not surprising given that you'd need a good reason to do an emergency tracheostomy. They can then be done semi-electively, or they can be done in a fully elective fashion. The indications for tracheostomy are probably best divided into three separate categories. There are airway problems that may require a tracheostomy, there are lung problems that may require a tracheostomy, and then there are other reasons. I'll give you 30 seconds to list as many possible indications for tracheostomy as you can think of, and I warn you there are plenty. So here's my slide looking at indications. These are some airway problems, tumours, infection, subglottic stenosis, foreign body obstruction, indication for an emergency tracheostomy. Here are some lung problems, the desire to reduce anatomical dead space, patients with diaphragmatic dysfunction. And then there are other reasons, and you'll have seen patients with neuromuscular disease who have a long-term tracheostomy or perhaps chronic aspiration. The timing of tracheostomy on ICU is something of a contentious subject. What does the evidence suggest is the optimum timing for tracheostomy in the critically ill patient? It perhaps won't surprise you to know that when it comes to the timing of tracheostomy on ITU, there is a good deal of contention. Clearly things ought to be individualised on a patient level basis. There are some patients who are clearly going to require long-term ventilation, head injury patients, perhaps also patients with Guillain-Barré who probably benefit from having a tracheostomy performed earlier in their care pathway. For others, it can be much more uncertain. The benefit of an early tracheostomy is to reduce levels of sedation and to have the patient awake and interacting earlier. The potential benefits of a late tracheostomy are to reduce the complications that derive from tracheostomy and also to give the patient an opportunity to be extubated to a spontaneous airway. The TrackMan trial was the UK's attempt at answering the question. It recruited rather slowly, took 7 years to get 900 patients. And in TrackMan, tracheostomy within 4 days of critical care admission was not associated with improved 30-day mortality, nor in any of their important secondary outcomes. Cochrane looked at a collection of nearly 2,000 patients. They suggested that late tracheostomy had lower risk of mortality. Looking at VAP, Lancet showed that the incidence of ventilator-associated pneumonia was reduced in early tracheostomy, but that this didn't go forwards to producing any mortality benefit. Meng, a meta-analysis of 2,000 odd patients, early tracheostomy might be able to reduce the duration of sedation, but didn't significantly alter mortality or incidence of VAP in this analysis. Another meta-analysis of over 2,000 patients, no evidence that early tracheostomy reduced mortality. Early tracheostomy did lead to a patient having more procedures, but also a shorter duration of sedation. The answer probably lies somewhere between the two, that a tracheostomy performed 7 to 10 days is optimal if it's thought that the patient is not going to extubate readily. Looking at the pros and cons of tracheostomy, well, tracheostomy has many potential advantages. It's more comfortable for patients, it reduces oral injury, and it's easier to toilet the upper airway and both the mouth. It's much easier to brush the patient's teeth, for example, with a tracheostomy. It's clearly much easier for the patient to communicate. There's a reduced dead space and potentially a lower work of breathing. It's also possible that patients can eat and drink with a tracheostomy, although this does remain somewhat controversial with thoughts that aspiration is an ongoing risk. The disadvantages of tracheostomy really relate to acute surgical complications, bleeding, infection and damage to the posterior tracheal wall, or even creating a fistula through to the esophagus, and late surgical complications including tracheostenosis, recurrent laryngeal nerve palsy and infection. Scarring is inevitable and for most patients is considered cosmetically acceptable, but clearly it is there. So I'm going to go on and have a think about the complications of tracheostomy. Possible to divide the complications into immediate complications occurring during or immediately after the procedure, early complications which occur during the patient's hospital stay, and then those late or later complications and those which can occur post decannulation. NAP4, which investigates complications within anaesthesia and critical care, looked at 184 airway events. In the study, tracheostomy failure accounted for 10% of those problems. Meta-analysis of death showed that death occurred in 1 in 600 tracheostomies, 30% during the procedure, and a further 50% of those within 7 days. The main causes of death were hemorrhage and airway complications. There's also risks of hypoxia and hypercarbia during the procedure, along with air embolism, aspiration, and terminal loss of the airway. If we look at the early complications, tube misplacement occurs in 0.35 to 2.6%. Infection is relatively uncommon but occurs in 1 in 20, and it's rarely severe with necrotizing features or a mediastinitis, which is pretty much universally fatal, really. You can develop a tracheoesophageal fistula early on. This is mostly fatal, but as you can see, quite uncommon. I'm going to talk about managing tracheostomies next. So, question: what is the most important difference between a tracheostomy and a laryngectomy? So in a laryngectomy, the entire larynx is removed. This includes the vocal folds, the hyoid bone, the epiglottis, the thyroid and cricoid cartilages, and a few tracheal rings. Speech is possible, generally using a tracheoesophageal puncture valve, which allows the air to pass from the trachea to the esophagus and through the valve. The trachea cannot be accessed through the mouth when a laryngectomy is present. Next question. When a patient with a tracheostomy is struggling to breathe, how should you apply oxygen? And thinking now about tracheostomy tubes. The National Tracheostomy Safety Project was set up in response to challenges with tracheostomies in the UK. They run a beautiful website with some very nice videos which would well be worth a few minutes of your time, perhaps especially the videos if you're at all uncertain in how to manage a tracheostomy in an emergency. You can see from this chart that the very first thing is always to get help. Tracheostomy management can get challenging, and you don't want to be alone. In the breathing patient, then high flow oxygen should be applied to both the face and the tracheostomy in the first instance, before you then go on to assess the patency of the tracheostomy. Speaking valves or caps should be taken off, and the inner tube should be taken out as well. You may need to put the inner tube back in if you're going to ventilate the patient using an ambu bag or a water circuit, which is the green bag. See if you can pass a suction catheter down the tracheostomy. If you can, then the tube is patent, and there's a list of things to consider there. If you can't get a suction catheter down, then the cuff should be deflated to allow the patient to breathe around the tracheostomy. If the patient can't breathe around the tracheostomy, then you should take the apparatus out, and you then go on to proceed down the chart as you can read for yourself. Considering now laryngectomies. So here is the flow chart for the emergency management of a patient in trouble with a laryngectomy. If the patient is breathing, then you apply high flow to the laryngectomy stoma. If it's at all unclear whether the patient has a laryngectomy or a tracheostomy, then there's no harm in applying oxygen to the face as well. You then need to assess the patency of the laryngectomy. Most laryngectomy stomas won't have a tube in place, but if there is one, then that should come out before you try and pass a suction catheter. Don't remove a valve that's present, that's going through to the esophagus, and you could cause damage to both structures on the way out. And you can follow the chart as below. The laryngectomy patient who doesn't have a patent stoma is in a significant degree of difficulty, and you certainly need emergency help, although that should be present from the outset. Thinking further about potential early complications, delayed hemorrhage occurs in 1 to 2% of all tracheostomy patients. It is frankly terrifying. It usually results from a tracheoinominate fistula, so a fistula between the trachea and the innominate artery, they can occur up to 4 weeks post-insertion. The tracheostomy tube can start pulsating, and there may be a slight dribble of blood before things become close to catastrophic. Hemorrhage is universally fatal without surgical management, and even with surgical management, a considerable number will unfortunately die. The risk factors are as listed above. It can follow on from local infection of the wound, also from radiation or steroids. Before getting the patient to theatre, temporary measures can include overinflating the cuff to try and compress on the artery. The tracheostomy should be kept in place, and you can press on the trachea or try and press the artery against the sternum. Looking now at later complications. Depending on what you read, tracheal stenosis can occur in between 30 and 85% of patients after tracheostomy. A smaller number require intervention, which can be lasering of the trachea or other surgery. Obesity is a major risk factor. Delayed wound closure occurs in a number of patients, and cosmetic deformities, including keloid, again a rarer complication. Tracheomalacia is possible, as is the development of a granuloma, occurring between 20 and 64% of long-term tracheostomy patients. Voice changes can occur long-term. The National Tracheostomy Safety Project advocates the use of signs over the bed in all patients with tracheostomies and laryngectomies. This is an example for a patient with a tracheostomy, demonstrating that it's a surgical tracheostomy and that intubation was difficult, with hints on who to call in event of difficulties. Regarding tracheostomy care on the ward, all tracheostomies should have an inner tube in place. The use of humidified oxygen reduces risk of tube blockage with mucus, etc. We've talked about the use of signs over the bed. Ideally, one would aim not to change a tracheostomy tube before 14 days after the first insertion. The stoma is at risk of closing, and a bedside tracheostomy kit should be available at all times. That's the end of this presentation. I would, of course, be delighted to take any questions that you have about this. Here's a list of references. As I said earlier, I highly recommend looking at the National Tracheostomy Safety Project website at the bottom there.